Thank you very much. It's a very, very nice introduction, and I hope that you will be so excited after the talk that you will be willing to scan these patients. So basically, I've been collaborating with many ultrasound companies and doing measurements in both children and adults. And I've been scanning patients for MASH for more than 15 years now. And you know that these numbers, the number of patients with involved with MASH is so huge. You see that almost 60 to 70 type 2 diabetic patient has a potential to develop MASH, obese patients, and metabolic syndromes. And the concept of metabolic syndrome has really evolved on the past 2 years. You see the prevalence in the United States of 38%, and this is also affecting children and teenagers. And now we separate the MASLD patients. These are metabolic dysfunction associated with steatotic liver disease, which are the previous NAFLD, which is almost 32% of patients, and is supposed to increase up to 41% in the projections, and metabolic dysfunction associated steatohepatitis, which is the MASH. Previous was NASH, and estimated prevalence in adults is 5%. But because of the very recent change and new medication, we expect the number to remain identical or even to get lower. And that's a major impact. So the new classification started in 2023. And as I showed before, you have alcohol and specific disease in one side. You have the metabolic dysfunction associated steatotic liver disease, the MASLD. And in between, you have patient with mixed alcohol and MASLD disease. So this is a very new introduction, very important. And MASLD can lead to MASH, which is the development of the inflammation on the liver and the ballooning of the hepatocytes. So MASLD is really defined with the presence of abnormal clinical or biological measurements. Mainly, this is the metabolic dysfunction. And this concept is so important that I would really like you to spend a few minutes. If you have a steatosis and one or more of the cardiovascular risk factors, then you are at risk and you have MASLD, you have the metabolic associated steatotic liver disease. So, and these cardiometabolic dysfunction are really very wide. You have the obesity, the waist circumference, the diabetic or even pre-diabetic patients, triglycerides, cholesterol, and blood hypertension that are involved in this disease. But MASLD is really a metabolic abnormal, a metabolic disease. So we have in one side the metabolic syndrome. You have the type 2 diabetic. You see that it increased by 2.5 the risk of liver dysfunction. But it is not only liver disease, because it's associated with blood hypertension, with cardiovascular disease. 43% increase of cardiovascular disease and chronic kidney disease as well. So this is a very broad disease that is not limited of being just obese and having some abnormal steatosis. Just with the eye, you're doing a great job in separating the normal liver to the steatotic livers. But just, and I will show you the numbers and a study that we published recently, by eye, you're not able to stage the disease. I mean, to separate moderate steatosis to severe steatosis. So eye is doing a pretty good job, and MR is our reference. Mainly, MR is a reference for MR-PDFF measurements. And PDFF is the proton density fat fraction, and this is a sequence that really provides you a number, a percentage of fat in the liver, and you have the threshold that varies a little bit in depending the studies. So if you want to do stiffness measurements, you have either the transient elastography, or you can do single point measurements. So you do the measurement at one area, or you do single frame acquisition, and you do, or you can do even real-time acquisition. My preference is always to go step by step, and I prefer to split the acquisition for stiffness to the acquisition for attenuation. And then you have, for quantification of steatosis, you have the hepatorenal ratio, so the brightness of the liver compared to the adjacent right kidney. But you have also attenuation measurements, and maybe in the future some techniques that just bring directly the fat fraction in the liver. And new measurements, new interest is coming from quantification of inflammation. So liver stiffness measurement seems very easy, but it is a very difficult measurement, and all companies have been doing a great job in getting this measurement, because the amplitude of the shear wave is 1,000 below the amplitude of the speed of sound. I mean, this is really weak signals. And you should be very careful when you're doing these signals, because they're very close to the signals of the noise. And so this measurement is not an easy measurement. It's not like color Doppler. This measurement is really very tough and needs deep optimization inside the ultrasound system. And of course, there are quality control during your acquisition that are very important. You should always be trying to do dual real-time, imaging to really look at the position of the vessel. Use the quality map with a quality index above 70%. The position of the measurement box should be at least 1.5 centimeter below the anterior capsule of the liver. You should adjust the acquisition to avoid artifacts or vessels, and perform typically 10 consecutive measurements. And we are investigating how many measurements we should be doing, mainly in segments 6, 5, and 8. You can use also segment 7, but it's more difficult. So just focusing, you do the 10 consecutive measurements, but you should always keep some criticism in your measurements. If you have discordance, or if your interquartile range divided by median is above 30%, you should be excluding some of the out of range measurements and redo some measurements. And initial results were pretty good, showing good differentiation between the several stages of fibrosis, but we know that from the very well controlled studies to the real life, there might be some differences. But the confounding factors when you're doing these kind of measurements are very important. They're not exactly the same between adults and teenagers, but basically you should always be careful on patient confounding factors or practice confounding factors. And in this practice, because this is something you can control, you should be looking at ultrasound reverberation, suboptimal acoustic windows, the intercostal wall thickness, and the good position of the probe in the intercostal wall. And the key question that we always underestimate is the breath control. The movement is our enemy, whatever the sequence we're using for both UGAP or shear wave measurement. And we don't see the measurement because at the moment you get the acquisition, the machine is frozen, and you don't see continuously the movement. And so that's why I will show you some tricks to avoid that effect. So the first thing that we have for evaluation of fatty content in the liver is the hepatorenal ratio. You can do it by eye. Is the liver really bright compared to the adjacent kidney? But that's not an easy when you don't have a kidney adjacent to the liver, or there's no kidney, or there's a diseased kidney, and we know that this is quite common in the adult population. You saw also the number of chronic kidney disease in the MASH population. So just by the eye, you're capable of doing some kind of evaluation. And recently we published the paper coming from our group showing that if we want to differentiate steatosis to non-steatosis, we're doing a pretty good job with a sensitivity of 83%, specificity of 80%. But when we're trying to go further and see S01 versus 2 and 3, or S02, 0 to 2 and versus 3, that's severe steatosis, then you see the numbers. The numbers are totally different. And this is a bicentric study on more than 350 patients with a correlation to biopsy and MR. That was a very, very big study showing some of the limitation of the hepatorenal ratio. So to evaluate the fat content, we can always, all companies develop attenuation measurements. But in principle, it looks easy. Just get the attenuation. But that's extremely complex, as complex probably as shear wave elastography, because the amount of energy that you should be able to measure is extremely low again. And you're facing very difficult issues dealing with all the post-processing sequence. So to be able to do that kind of measurement, all companies had to remove most of the post-processing and also compensate for many of the artifacts that are present in the image and that you cannot see. So it's not like something like, you know, you push a button, oh yeah, of course I'm getting my UGAP. No, in fact, it needs a really strong evaluation. And this is one of the first wide study published showing good results. But look at the dispersion of the values. And that's clearly one of the issues, is how many dispersion we have. So we've been working with GE in order to more standardize the acquisition. And I would like to show you the preliminary results. These results are not published, so please don't take pictures. These numbers are really confidential. And I hope to get it published soon. So this is on teenagers and adults referred for liver shear wave elastography and fat quantification. And again, look at the numbers. We had 250 patients enrolled, and finally only, not too bad, but 156 MR PDFF. So of course we are losing patients in between recruitment and MRI just because MR is not comfortable. It's not easy for very obese patients because of stress, because of their weight, and because of fitting inside the system. So this is the overall studies. So what I'm showing now is the metabolic-associated fatty liver disease in children, the one in adults. Now we're getting more adults, and a very specific population of vascular chronic liver disease. And these are patients with a cardiac surgery and residual hypertension, venous hypertension that really impact in the liver function. So these are congestive livers. And you have the numbers here, the gender and the BMI. And again, BMI is totally different if we look at the pediatric population. So these are very big patients. Look at BMI from 24 to 56. And this is a median value, 36 to 30, and this is highly significant. So adults are more skinny, I would say, relatively more skinny. And the vascular patients are really 22. They're totally normal. They're no obese at all. And all of this is different. And so we did the MR PDFF. And of course, we found that the rate of failure And this is something that is not appearing so much in the study. The rate of failure is about 7% of the patients. So that's interesting. It's not just patient that getting inside. They agree to participate. They agree to get the MR, and then they're getting inside the machine, and then they said, no, I cannot do it, and they're just getting out. And here you have the values, mean and variance. So, and for liver fat quantification, so this is the number for hepatorenal ratio. Again, we had a rate of failure of 6% all over the studies, just because sometimes it is not possible to get the kidney in regard of the right liver, or because some of them are renal transplanted patients, and we know that they are exposed to MASH also. And of course, you cannot get the transplant kidney against the liver. And these are the rate of failure, with a Canon system, because we use the Canon system as a comparative for attenuation measurement. And we use the supersonic Mach 30 system for mostly shear wave elastography reference, because this is our reference system. So you see the rate of failure is really, really low in that case. And you see that with the Logic E10, we had the same kind of a failure in only one case. So, I mean, this is becoming part of our routine examination. So, first, looking at the hepatorenal ratio, we split the values between S0, S1, S2, and 3. And you see that the p-value really low, meaning that there's a very good correlation between hepatorenal ratio and the liver fat content. The Spearman and Pearson coefficient are really significant, highly significant. However, if you carefully look at the data, because I mean, people are mostly saying, oh, this is significant. But when you look at the data, you see the overlap, and you understand why, it's not easy to separate S0 from S1 and even S2 to S3. So the several stages of steatosis are very difficult to split, and you see that for S2 and S3, there's no significance. However, the ROC curve and the area under the curve are acceptable, I think, from 0.77, and for S01 to S2 and 3, 0.73, which is not too bad, I would say. And the area under the curve, if you're looking at mixed, is between 0.77 to 0.83. I mean, they're acceptable. They're not excellent, and the ideal situation would be 0.99, but they're not too bad. Now we're looking at the steatosis measurements, and this is attenuation. And you see that both, first you see that there are differences between systems. I mean, they're measuring the same attenuation, but the values are really different. You see that the Mach system, for example, had much lower values. And on the previous published paper from Casinoto was doing a much poor job. However, you see that there's no really significant difference in between the systems. All systems are capable of doing this kind of measurement with a pretty good correlation to the grade of steatosis, and it is coming from MR measurements of PDFF. However, you can note that the lowest coefficient correlation is still provided by the G system. I don't mean that this is significant, but note that the system is doing a really good job. And if we go now for the area under the curve, looking at attenuation, you see that all systems are doing a good job, but nevertheless, this is just numbers, and this is just a scientific study. There's nothing promotional, but you see that the numbers coming with the G system are slightly, or at least as good as the best, as the other systems. And if we go to the literature, and this is the Casinoto paper. Casinoto paper is a kind of mixed. If you really carefully read it, you'll be surprised that it has been published in such a good journal as Radiology, because it's a mix of many kind of chronic liver disease, not only focusing on MFLD, but there's 200 patients with MFLD, but the results are provided in the overall population. And you see that the performance of the three systems, and this is very similar to what we did. In fact, we tried to reproduce the study is in the numbers that I had, except that they are slightly lower than what we had, and I can explain why at the end. The key point when you're doing a measurement is to look at the variability of the measurement. And I think that this is even more important than what we're doing. So I've been looking at the variability using interquartile range divided by median. And you see that these numbers vary with the type of population. Here you have the adult MASH. Here you have the pediatric MASH. And here you have the chronic liver disease due to vascular cause. So there are some differences between the two of the three populations, but nevertheless, they're very comparable. Probably the supersonic system is the one that is doing a slightly less good job, but the results are still there. And when we look at the variability coefficient, and this is interquartile range divided by median, you see that all probes are doing a good job, except maybe I told you the supersonic one, and you see that the overall values are comparable. At least there's no difference in between the systems. If you're going now to shear wave measurements, again, we did 5 consecutive measurements, and we took the median value for all 3 systems. The supersonic is our reference for shear wave elastography, and we split it the population in we also looked at the interquartile range divided by median. And now here you see a slightly higher variability on the G system. And this is the kind of results that we got, very similar to what we had for MASH. And you have here the interquartile range for shear wave elastography measurements on the 3 groups, and you see some here, some outline values that we are working on it. Probably, movement again is our enemy, and this is making measurements more difficult. However, if we just consider the overall picture, you see that all systems are doing a pretty good job, and we splitted the stage depending on the values of the paper published by Herman, and this is how we splitted the values. And then you see quite a nice difference in between the stage of steatosis, depending on the fibrosis, that you can see here, depending on the systems. So all systems are doing a pretty good job, but nevertheless, the logic system is doing significant quality measurements. In some cases, you see that there's no significance between the category of the population, and this is using the supersonic as a reference to split the stage of fibrosis. But it is interesting to see that we are able to split the several population of fibrosis as defined by the measurement done on the supersonic system. And at the end, if we go to a more simple view, we have the F0, F1, so mild or no fibrosis, to F2 to F4, which is significant fibrosis. We can split the population, and you see the sensitivity and specificity that we can get using the optimal threshold that is calculated from maximizing the Undan's index. So the Undan index is a parameter that we use in statistics to calculate that. And you see that both systems are doing a pretty good job. However, there's some kind of outline values here that can affect really the measurement. So looking at the ROC curve, again, you see that the IUC F0, F1 versus F224 is really similar. So we can say that both systems are doing a great job. So at the end, you have the combination of a shear wave elasticity and UGAP to characterize the liver fatty infiltration and the level of fibrosis. It is a nonsense to do just quantification of the fat, because as you understood, the quantification of the fibrosis in this population is really the key and will change the patient management. And of course, when you see such a bright liver, a steatotic liver, despite the fact that this patient is not obese, he's only BMI 29, 86 kilogram. So you look at the liver, it's obvious that you have a massive, or at least steatosis, and then you're getting the measurement with the Shear Wave Elastography, and here UGAP, and you have all the numbers here, and you see that the median measurement is around 6.8 kilopascal. So there's some kind of fibrosis in the liver and a very significant amount of steatosis, because you see that the median value is 0.84 for attenuation. So clearly, this patient had severe steatosis, what you got, just by the eye. But again, the eye is not able to make differentiation between mild or severe steatosis. It's a better understanding of the MASH disease and the progression of the MASH. And this is something we are looking at, is follow-up of patients with these ultrasound tools, because they are much better accepted than the MR measurements. And this is true in both teenagers and adults. Attenuation and shear wave should be done together, and they have a similar clinical performance in between the ultrasound system, meaning that we are able to follow the patient, diagnose the patient. There's a major value of training, again, and a very strict study protocol. And I would like to show you some of the tricks if we are on time, and we are on time. And for the future, of course, we would love to get liver fat fraction measurements, but I know that all companies are working on this. And the ultimate stage is, of course, to be able to follow up these patients. And I think that this is exactly what we would like to do. Okay, so if you have any question, I'll be happy to take them. And then maybe we have a few minutes more for scanning, and you can or either look at me scanning, or you can come and scan, and it can get you some of my tricks. Thank you.